Okay, in this last section of Chapter 4, we are going to talk about the metabolic effects of brain injury and a process called excitotoxicity and the effects of rehabilitation on plasticity. So, neurons that are deprived of oxygen for prolonged periods of time die and do not regenerate. So, for example, when you have an ischemic stroke, there's a clot that blocks off the blood to a certain area of the brain. Those neurons are deprived of oxygen and they die. So a process called excitotoxicity, which we will talk a little bit more about, might even add more damage beyond the neurons that were deprived of oxygen. So there's really no known drug that provides neuroprotection for people that have a stroke or a traumatic brain injury or a neurodegenerative disease at this point. There's research going on that's trying to find other ways to restore nervous system damage. So like promoting angiogenesis, which is the formation of new blood supply, and neurogenesis, which is the formation of new neurons. So excitotoxicity, you should know the definition of that. It's basically the overexcitation of a neuron that leads to cell death. So there's a cascade of events that happens that contributes to neuron damage associated with CVAs and traumatic brain injuries. When those oxygen-deprived nerve cells die, they release a chemical called glutamate. They release a lot of it. The glutamate produces a cascade of cell death. So there's this figure 4.7 on page 75, which is right here. So the initial event via a CVA or TBI is ischemia, where an area of the brain is deprived of oxygen. Okay, those oxygen-deprived neurons release glutamate. The glutamate activates calcium channels and the release of internal calcium stores. Okay, so 3 different paths that can happen that can lead to cell injury and death. One of them is you get increased glycolysis, which is part of cellular metabolism. The byproduct of that is lactic acid. That leads to cell injury and death. The second thing that happens as a result of that glutamate release is you get increased intracellular water, which causes cell swelling and again leads to cell injury and death. Another thing that happens as a result of that glutamate release, the third thing, is you get activated protein enzymes. Enzymes are often catalysts in metabolic reactions. Those metabolic reactions produce more oxygen-free radicals, and again it leads to cell injury and death. So basically, the ischemia kills some cells by depriving them of oxygen. The death of those cells releases glutamate, which then kills some additional cells around it. So it's not just the initial cells that were deprived of oxygen that are damaged in a brain injury or CVA. It's also the cells around it because of this excitotoxicity. And the excitotoxicity, again, is overexcitation of a neuron causing it to release excess glutamate. Okay, so really the 3 bad things that result from that are excess lactic acid, cellular swelling, and oxygen-free radicals, and those all contribute to cell injury and death. So bad things. So rehabilitation and its timing can really have an effect on recovery of function after a brain injury. So the timing and intensity of rehab are really important in regaining function. So you really need early rehabilitation for improved outcomes. So when someone comes into the hospital in the acute care setting, and it's determined that they have had a traumatic brain injury or a CVA, they start getting rehab immediately, as long as they're medically stable. So a lot of times if you're working in an acute care setting, you will see these people in their early stages of rehabilitation, which is really cool. So it is it is really interesting working with people in the early stage, because a lot of times they are in neural shock. They don't know what's happened. They have so we need to actually get them working on functional activities to prevent loss of function in adjacent undamaged regions, of the brain. So if they're just inactive, which is what used to happen when someone had a stroke, they would get admitted to the hospital and they would be inactive and they would have more damage afterwards. So if we can start with low-level functional activity, we can prevent loss of function. The rehab affects reorganization of undamaged regions of the motor cortex. So the sooner we start using it, the better. However, you do want to limit your activity to less intense activity during the acute phase, because you don't want to cause excitotoxicity and cause more cell death. So we'll talk a little bit more about the timing, but really you need task-specific training, because you get more regular patterns of brain activation compared with general use training. So you're training people on specific things like transfers, bed mobility, standing, balance, using their hand to reach for something. You don't want it to be excessively vigorous too soon after the injury, because that can actually be counterproductive. So it's really important to learn when you're in your clinicals and when you're working in that type of setting, how soon you can start to do more with someone with stroke. And I have worked in the acute care setting, and a lot of times you are trying to assess whether or not that patient can tolerate something more vigorous, like an inpatient rehabilitation program, versus going to a skilled nursing facility where they will get more low-level training, because if you try to do it too soon, you can actually cause problems later on. So once you've moved from the acute stage through the subacute stage into the chronic stage, they actually use a thing called constraint-induced therapy to recover or increase function on the involved side. And this uses neuroplasticity by unmasking some of those silent neurons and getting to the neurons that are still intact to increase their function. However, there's some case-specific information in the book about how too early rehab and using constraint therapy in the acute stage can actually be detrimental. So there is a little video, it's about 2.5 minutes, on constraint-induced therapy, and you'll see the person is not in the acute phase, they're far beyond that in the chronic phase, but it's really interesting how they do it. They actually take the more functional arm and restrain it, so they have to use their affected limb in order to do activities, and it shows an increase in function. So what you want to do is you want to between 5 to 30 days, you want to actually start rehab 5 days after the CVA, if it's task oriented and not too intense. So intensity and the timing of rehab can really influence recovery. So you want to make sure that you're doing something that is appropriate for the level where that person is. So definitely watch that video on constraint-induced therapy, because it is a really interesting therapy. And certainly you're going to be doing that in an outpatient setting or in a skilled nursing setting when someone is farther down the road with recovery on their stroke. Okay, so in the next chapter, chapter 5, we're going to be talking about development of the nervous system. There's quite a lot of information in there about specific neural formation and that sort of thing, which we are going to gloss over. And we're going to talk about a little more about critical periods in development and developmental disorders. So that will be in Chapter 5.